It's with great pleasure that I welcome our next speaker, Simon Weldon, who is the Regional Director of Operations and Delivery here in London for NHS England. And in that role, of course, he's also Director of Commissioning for the London region, and this includes responsibility for commissioning of primary care and public health for London and specialised services for London and for the whole of England. Simon, of course, has the background to do that, having come from North West London PCT cluster, where he was also Director of Commissioning and Performance and was responsible for commissioning London Ambulance Service. So Simon, welcome, and we look forward to hearing your talk.
Thanks, Howard. So, good morning. It's great to see so many people here. You can see in the bar up the top there what I'm going to talk about, really. I'm going to start by giving an overview of the system in London and where we've been over the last 3 years. You'll know that the Secretary of State set us all a challenge in terms of what our recovery and improvement plans look like, and I'm going to talk a little bit about what we found in the first tranche of assessment across London. Then I'm going to pick out 3 or 4 themes that I think are particularly important and finally suggest some next steps. So the first graph here is quite a stark one for me, really, because it sets out that year on year over the last 3 to 4 years we have seen performance deteriorate. And the message in this graph is quite straightforward for me at the moment. It says that, as you can see in our yellow line, although we are now achieving and did achieve Q1 as a performance standard, we're still tracking below last year, below the previous year, and below the year before that. And that tells us, pretty certainly, that if we don't take fairly concerted and consistent action, we could expect a longer, harder winter in terms of performance than we've ever had before. And although Heatwave 3 is upon us, so I'm supposed to do a plug here for Heatwave 3 and check that everybody is taking the appropriate actions for this weekend, winter is also upon us, and we know that the time it takes to get winter plans in place is actually very significant. So my key message is that this planning has to start now. But although performance has dropped over the last few years, you can see attendances varying within a given range very insignificantly. There hasn't been a great deal of variation at all. And although we've seen some data collection changes, what we know is that attendances have remained static. We know too that although admissions have increased, they are marginal in terms of their increase, and we haven't seen huge swathes of people turning up at A&E departments and being admitted. So we've got a position where performance is declining on aggregate over the last 2 to 3 years. Attendances are relatively flat, and admissions, although increasing, only doing so marginally. And here is the SITREP data that we're all familiar with, many of us who spent happy hours over the winter filling these in. You can just see another take on this data, which shows again that in actual fact improvement was there in some of those aggregate SITREP indicators. Yet again, we see that performance deteriorated. We've spent a lot of time, and I know many of you in this room have spent a lot of time thinking about what the causes of that performance dip have been. And we've got a number of reasons suggested that you've suggested to us here. So the first, acuity. So it does appear that from some of the work that you've been doing, there is greater acuity in some of the attendances that have come in, and there is evidence that there is a higher conversion rate in some of those admissions, suggestive of something to do with acuity, though there is no consistent picture, and I should stress we have not yet done London-wide work in this space. You can see too and Anne Radmore, Chief Executive of LAS, will talk a little bit about this later, that ambulance service pressure has also increased. So acuity, certainly something to think about. We had a longer, colder winter here, and that winter certainly had an impact. We saw performance continue to be challenged right out through April. And finally, a theme to which I will come back. We know, because we looked at bed reductions, and we've done so for each of the last 2 years, what the aggregate number of beds is in London for G&A, general and acute beds. 2 years ago, we reduced bed capacity by about 700 beds across London. Last year, we did by 600. So you put more admissions through less beds, and that clearly then challenges bed occupancy, and bed occupancy was around 96%. What we know about that, and I'm really glad that we'll have Kate Sylvester talking to us later on today, what we know about that in terms of process through hospitals is that it makes it very, very difficult for people to cope. And here now is some of the data that shows us some detail around that. So if you look here, as we start to delve into some of the detail, so what did that performance look like in reality? Well, this is a trust in London. It has been anonymised for obvious reasons, but you can see the scale of the Monday challenge as it is there. And it means in stark terms that for people who needed admission, less than 1 in 4 of them at certain points in the day, these are our sickest patients, less than 1 in 4 of them made it through the eye of the needle in under 4 hours or less. Quite stark, really. And you can see from this graph that this is a system that is fundamentally not in control. The variation reminds you that it's not in control. I'll make a processy point here, I suppose, to say that how many people are still using data like this to govern the performance of their systems, and how many urgent care boards are understanding their flows by using data like this. So this is this year's data. As you can see, it was the week of March 2013. It was a Monday, and you can see that it was very, very significantly challenged. The bottom bar there represents the number of 12-hour breaches. You can see, too, the Monday challenge again. So look at the colour there in terms of waits for beds. And clearly, relating to my previous point, access and data, access for beds remains a critical challenge. But it's not just that, is it? Because that graph also shows that waits for assessment, waits for specialists are on the up in this department. But look at that clustering of waiting for beds. And this was pretty consistent across a number of trusts in London. Again, my question, how many of us are looking at this data and still doing, I was around in doing some of the first, getting up to the first 4-hour challenge, and I remember doing breach analysis very consistently. How many of us still do breach analysis and try and understand what the causes of the problems are? And finally, a graph that certainly I used to be very familiar with, but if you look here, late assessment. So assessment which shows that people are bunching at the end of the 4-hour pathway to be seen, assessed, and then treated. And again, if you put that picture together, you've got across London pressures across the system on Monday, where you've got numbers of systems where delays for first assessment, delays for beds, late assessment are leading to an incredibly poor quality of patient experience in the system. This cannot be good for patients. All the data, this isn't about the 4-hour target for me. This actually just tells a story around patient experience. which for all of us in this room must be, I think, an unacceptable place for us to be. And we have to address it. So to turn now to the challenge that was set by the Secretary of State in the post-winter analysis. So we were asked across the country, and this is one of 4 regional events that's taking place across the country, to look at recovery and improvement plans, which had to pick up evidence-based improvement projects with root cause analysis, clear pre- and post- and in-hospital care. And I do want to pause there saying, although I've spent quite a lot of my last few remarks talking about hospitals, I firmly believe that the hospital is just one part of the whole system, and it is as much about what you do before the patient gets to hospital, once they get to hospital, and what you can do to get them out of hospital. And I'll say a bit more about that when I come to the urgent care boards. Triangulation of demand and capacity. It has been an undeniable truth that everybody has had to save money, and one of the ways in which people have done that is reduce capacity. It's not just in hospital, it is out of hospital. But capacity that is taken out without understanding its impact, without understanding what it will do in the context of demand, is a fruitless and short-term gain. We will talk later on about 7-day working arrangements, and I'm really pleased that Andy Mitchell, who's our medical director, will say some more about what that means in terms of the quality of standards. We have to work also to make sure that the whole system aligns around contractual arrangements and levers to improve performance. So, as you know, we had to submit at the end of July where we were. So here's where we are in London as we speak right now. We've got 7 trusts or systems that have got fully assured plans in terms of the recovery improvement plans. We've got the majority who are partially assured and 3 who are not assured. And here's what was good in some of those plans, and here's what still needs strengthening. It was clear that there was a system-wide approach to the development of plans. It was clear that the majority of plans were identifying areas outlined in the national guidance. What was really cheering to see was that there was evidence that systems were coming together. People were coming together. It was not just being seen as a hospital problem, it was being seen as something that everybody had together to deliver. We saw specific schemes emerging to help high-intensity users of A&E at particular times, so the alcohol schemes in Lambeth and Southwark. We have seen consistent and considerable effort around primary care access, and we've seen a lot of work going into integrated care initiatives. But I suppose it's unclear still in some of the plans what the out-of-hospital system is going to look like to really make a maximum impact. Mental health, although smaller in terms of attendances, as those who run A&E departments know, can have a huge impact on the quality of care for both those patients specifically, but also those around them. And we also know that the London Clinical Quality Standards, urgent care boards and systems are grappling with these, but we can see variable implementation, and I'll say a little bit more about that in a moment. So now I'm going to go on to 4 deep dive areas. The clinical quality standards, as I said, discharge and delay transfers of care, 7-day working, and finally, demand and capacity. So if we look at how far were the clinical quality standards referred to in the first draft of the plans, and here you can see just a very high-level analysis of what's going on. It shows, I think, on the positive side, that people are grappling with the question. The challenge is that you can see from the amber-coloured bars or the red-coloured bars, there is still a considerable journey to go here. We recognise that these are developmental standards, but everybody in this room, London as a whole, has signed up to the implementation of these standards. These are where we wish to get to. So my challenge to us in this context of this conversation is, where are we going to go with these standards? You'll have some time later today to reflect on these. But we know that by improving flow, and I'm sure Russell will be saying some more about this, by improving flow, you make a real difference not only to the patient experience, but also to outcomes that patients experience in emergency departments. Delayed transfers of care. We know that there is still huge variation in terms of how well systems are doing some of these things set out here. So there is still variation in specialty engagement around emergency department. There is still variation for internal professional standards for every ward. There is still variation around board rounds, around weekend discharge capacity. We have known these things for many years. They are all readily available, and I'm sure I don't need to explain them to you here. The challenge is that they have not yet still been applied consistently in every healthcare system. We know that there are still people who are medically fit, who aren't in the formal DTOC category, but who are staying in hospital far longer than they need to. So as we approach winter, what are we going to do to address some of these problems? Because that makes a material difference. 7-day working. It's an operating plan commitment, and you'll know from the operating from Everyone Counts that the national review will be reporting in autumn of this year. Everybody, I think, is engaging in that discussion, but you can see from the analysis here that the variation in what people are addressing at the moment remains significant. So I put this up here not to prescribe an answer at this stage, but to suggest to you that there is considerable work that can still be done in this space. Finally, to start to talk about demand and capacity, it's an absolute truism that improvement techniques have to be implemented in order to generate the efficiencies that are required when you take out beds. But often, and still even now, there are still challenges around those things. One challenge in Everyone Counts this year in our planning guidance was to make sure that there was a correlation between the cost improvement plans that systems were aiming for and linking those to capacity and plans and the ability to deliver care. The evidence shows that there is still some work to go in delivering that as an outcome. And often, partly assured plans focus just on one area, so focused on a hospital, not necessarily on the whole system. And a final point on this point is that not everybody, I think probably the biggest need that we experienced in terms of feedback for support when we came to look at these plans was how do we understand capacity? So here are our urgent care boards in London. You can see yours no doubt represented on here. Some are unitary to the borough that they involve. Some cover more than one area. It's just so that you know what we've got in London. But to start to talk about the challenge as we head for winter this year. So performance recovery for winter 10-11 occurred in January. In 11-12, this was not seen till February. For 12-13, this didn't come until May. Where will we be this winter? And capacity. So as I said earlier, the capacity, understanding demand and capacity is something that people have really been struggling with, really been grappling with. We've run a workshop across London to help systems think through what they need, and we're encouraging a common language across capacity this time in order to make sure that we understand capacity jointly. I want to emphasise this is not to say that all capacity has to be located in a hospital. That's absolutely not my message. It is, though, absolutely to say we have to understand the capacity that needs to be at all stages of this system in order to deliver an effective emergency care pathway. How many of you have such an understanding now in play for your system? Could you reference it? Would you know where your shortfalls are? Finally, a word on the friends and family test. Obviously a key policy priority. What we're pointing out here, I suppose, is that although people have made considerable strides on that in an inpatient setting, for A&Es it remains a significant challenge. I am inviting you to think about that as you develop your responses. It is key that we actually ask people how they experience our urgent care services. So the next steps then. So as I said, we've had our first tripartite panel. We've done our first submission. We will be responding to the National Review on Emergency Care, and I would encourage everybody to contribute to that. It is an important debate nationally to set the agenda for emergency care. We expect there to be winter guidance shortly for 13-14, and whether we'll have funding to support that. Hopefully that will be earlier this year. I know that's been a recurring issue for people, that hasn't been early enough in the system. We plan to have a winter scenario planning event in September, October, really focusing around the capacity piece. And there'll be a third tripartite panel in September, which will focus on those demand and capacity plans. It's vitally important, as I said at the start of this, to plan now, because where we've gone with winter in the past is normally we come back after the August break and we think in September, now is a good time to start planning for winter. It's clearly not a good time to start planning for winter. We need to spend at least 4 or 5 months getting those plans in place. And my challenge for London is that we've completed our winter planning by September. And that is it from me. So thank you very much for your attention.